So let's pick up with our interventions, with assessments and interventions for the thoracic spine. So our next intervention, which can also serve as an assessment, will be the facet lock and prone line stretch of T2 on T3. All right, great. Okay, so what I want to do, I want to mobilize. So I'm standing on her left side. I can stand on the right side too, but I'm standing on the left side, right? So I want to facet lock. I want to do a facet lock down to T2 on T3. All right, and so what I'm going to do is mobilize the spinous process of T3. I'm going to mobilize it towards the right, okay, to facilitate this stretch. But what it's going to do, this is what it's going to do. So this is, so let's do this. I'm going to get you back up. Stand up so everybody can see this. So come around everyone. Come around. It's basically demonstrated on Charlie first. All right. So we got 1, 2, 3, 4, 5, 6, 7. 1, 2, 3. So this is spinous process of T3. And so this is what I'm going to do. So my left thumb, so this makes it the way you can see it. My left thumb is going to be on the left side of the spinous process of T3. So what I want to do, I want to create a facet lock down to T2 on T3. So this is what I'm going to do. I'm going to side bend the patient to the left. So side bend down to that segment. So side bend down to that segment. And I'm going to rotate to the right. All right, so I side bend to the left and I rotate to the right. And then what I'm going to do, I'm trying to maintain is, I'm going to apply like a distraction at the occiput head. And as I do that, I'm going to be pushing T3 to the right. And as I impart this force, there should be facet lock right there. You'll try to maintain it right there for me. So, thank you. And so as I impart that force, what's going to happen with T2, there's going to be a stretch in between T2 and T3, but what's going to happen on the left side of T2 is going to do a PA. It's going to move posterior to anterior on the left side. So what that's going to help to do, that's going to help to improve forward bending at this segment, forward bending, and also help to improve rotation to the right of T2 on T3. Okay, so facet lock down to T2 on T3, come in, side bend to the left, rotation to the right, come in and add my distraction, and notice that I'm gonna have her slightly flex as well. So add my distraction along with this force pushing T3, my thumb pushing T3 to the right. All right. So now, come on, Devonna. So it's good to see it on your done. All right. So now, slight deflection. There we go. How's that? A little bit more. Okay. So now, so I'm gonna side bend you. I got a side bend to the level. Rotate to the right. So now I'm applying my distraction. Okay. So see right here, my thumb on the spinous process of T3. She side bent to that level, rotate it to the right. My hand's gonna come right here. And so, and she should feel the stretch. Felt a little jump there. What happened?
Pain.
Pain. So she may have some issues going on somewhere. Okay, so she has some reproduction of some symptoms, some pain. What kind of pain? How would you describe the nature of the pain?
Kind of sharp.
Kind of sharp. Okay. All right. So that will improve forward bending and rotation to where?
Right side.
Now I can do the same thing on this side. I come right here. Find T3, side bend to the right. She already rotated for me, so she helped me out. And then as I add my distraction, I'm moving the T3 spinous process to the left. And so that's improving forward bending of T2. On the right is going to PA, but it's improving forward bending and rotation to the left. Okay, and side bending is improving side bending. In this case, side bending to the right. Okay, the effect of this is a stretch of T2 on T3 facet, which would assist in forward bending, side bending, and rotation, depending on which side you're on. This is a specific technique to the upper thoracic spine, all right? It's most beneficial at the upper thoracic spine, T2, T3, maybe T3, T4, but beside that, you'll get lost because the cervical spine, mid-cervical spine, influences T1, T2, T2, T3, T3, T4. Beyond that, you get lost with this technique. So upper thoracic spine, you'll see this on your practical. It's most likely going to be specific to T2 on T3. All right. So if you see that, that cues you, especially for specificity with side bending and rotation. All right. Both sides are going to improve forward bending. So now you got to pay attention to limited side bending right at T2 on T3. What can you do? So now you have to know how to set the technique up. Next one, depression of the first rib. Okay, so this is a good one to assess, especially if your patient has thoracic outlet syndrome. Did we talk about thoracic outlet syndrome in this course? Did we?
Yes.
Yeah, we did. So we talked about soft tissue techniques and clinical ortho that will help with that as well. So now let's go depression of the first rib. So patient comes in complaining signs and symptoms that may be consistent with thoracic outlet syndrome. This most definitely you want to assess the first rib. It'll be very beneficial to assess it. Just based off observation, if the clavicle on one side looks more elevated than the clavicle on the other side, it could be a potential that also the first rib on the same side of the clavicle that looks elevated, it could likely be elevated as well. You don't know, it's just an observation, just a hypothesis, so then you can test it with your assessment and treatment. I'm gonna raise her up because I like to do this one standing. You can do it sitting as well if you're comfortable. So, as the slide says, you're gonna be posterior to the clavicle, okay? So we're gonna make sure posterior to the clavicle, lateral to the C7 transverse processes. So I'm gonna come in here. All right. So I know that I'm lateral to the C7 transverse processes. My thumbs are on her clavicle. So I am posterior to the clavicles because my thumb has contacted her clavicle. So as you can know, my index finger is posterior to the clavicle, all right? And you got the anterior to the spine of the scapula, okay, I'm there. So now what I want to do, instruct my patient to take a deep breath. So take a deep breath in your nose and blow out your mouth like blowing out a straw. Good. As she exhales, I'm going to follow that. Did you feel that?
Mm-hmm.
And right now I'm just focusing on the right side. So, and I'm holding it there. So now you're going to do the same thing again. Breathe in deeply. And I'm going to follow as she exhales. Any pain or discomfort?
Mm-hmm.
Okay, go ahead again. And just relax right there as I'm breathing. I'm just going to hold it right there. Okay. And one more time. So I'm holding the same amount of force when she breathes that I did as I follow. And relax. Good job. Any pain, discomfort? All right. Let's do the other side and assess. All right. Take a deep breath in for me. Good. Any pain, discomfort?
At first it was, but not no more now.
Okay. So she said at first it was some pain. Well, how would you describe the pain? What would be the nature of the pain?
I guess just more so from like the pressure.
Okay.
It wasn't radiating or nothing.
Okay.
But
And I didn't feel a significant difference when we're talking about hypermobility from side to side as I assessed while doing that. So that's a good simple technique that you can use that patients may have a problem with this. This could be a major problem. Have you seen this one a lot, Dr. McClure? Mm-hmm. So again, I even check this one when patients come in complaining of neck pain. Like they have ridiculous symptoms and it could be due to the neck pain or cervical radiculopathy. I still check the first rib. Come on, let me screen this quickly. It doesn't take long, less than 60 seconds. Mm-hmm. Okay, so this is what I would do with females. I'm a male. With females, I'm gonna do the modified version. Right. I could do the one I did with Callie right there, but I'm gonna go with the modified version. All right.
Do I need to rub
So
anything?
scoot back for me. Scoot back. Okay. All right. Bend forward for me. All right. Now bend backwards. Backward bend for me. Backward bend. Backward bend to the cervical spine.
Oh, sorry.
Okay. All right. I've localized C7. All right. Relax. I want this to be around C7, T1. All right. This can be tough. I tried to lower the plant as much as I could. All right. Now cross your arms across right here like so. All right, I'm gonna lean you forward, bias you forward. All right. Take a deep breath in for me. And blow out like blowing out a straw. Okay. And that was it. So you get up to the end range of extension, the C7 on T1, and then at the end you add your thrust. So high velocity, low amplitude.
Is it more you supposed to feel like the up like up here?
Yeah. Mm-hmm. So this is designated for C7 on T1. I can lower that if I want to, and see if I can get a little bit lower. So this one T2, T3. So come back up.
Y'all see the orientation of the towel?
Deep breath in for me. I don't know if I didn't hear an audible pop.
It's like just a
So
little bit.
it just depends
But up here, it was
on
a
the
little
person. So now with Jared, right? Now I gotta use technique. Cause I got like a linebacker. Jerry, you play football, didn't you?
Yes, sir.
What you play, offensive line?
Yes, sir.
Man, I could hurt myself with the offensive line. All right, scoot back. So now, all right, I'm not gonna worry about this. How? Well, let's see. All right, place your hands across your chest. This is better with him because he has some size. All right, come here. Come here, Andrew. Andrew, just like orient my towel for me. There we go. Bring it up a little bit more. Good. Now bring it, scoot it to the right just a little bit. There we go. Good. So now, take a deep breath in for me. And so I use my legs more so. So I didn't try to use a whole lot of upper body because he's an offensive lineman. I can hurt myself, throw my back out. So notice I squatted and came up like that. So I use my legs with Jerry. You get anything with that?
Little so.
So yeah. So sometimes with different patients you have to modify. But the focus was C7T1 and I had to have some help to get the towel to focus in on that area, that junction. Okay? It could be some work, you all, with that technique. You got any other modifications, Dr. McCurry?
Well, just comments. So, what about your patient with rotator cuff issues?
Yeah.
You're probably not going to do that one, right? You know, you're going to be careful about what you do with that. Also talk about secondary levers.
You don't know what you just
So it gets him here like this, right? So this gets him a little more flexed, so you get some ligamentous tension.
I can't get a good one on that one. So, but really, I'm up underneath as much as I can, trying to get him an extension and coming straight up.
Okay, at the arms.
Mm.
Okay.
All right, lie down on your stomach for me. Okay. You place your hands by your side. Place your hand. So this right here. So
Okay, that makes sense.
I'm gonna go T1 on T2 on the right transverse process of T2 or T1 on T2. So if I come right here, I could use my thumb on the transverse process of T2 and I could use a dummy thumb and impart a PA of the right transverse process of T2 on T3, right? And so now what's that's gonna help with? It can help with forward bending or either with rotation to the left to help improve those movements, okay? And what else? Side bending to the left because we gotta get an up glide, okay? So, so that's simple. It's simple PA.
Everybody's trying to get C7, it's a little hard to get that done.
So this is a PA glide, mid-thoracic. This is a thrust technique. All right. So PA glide with the patient supine thrust technique using hand shotgun technique. So you see my hand, right? Almost like a shotgun, a gun, pistol form. All right. So I got my pistol. So my middle finger, you see my middle finger? Is on the spinous process of T4. All right. So it's on the spinous process of T4. So as I lie the patient down, my middle finger is on the spinous process of T4. So my patient's arms are gonna be crossed, right? And I'm gonna have the patient take a deep breath in and exhale. As the patient exhale, I'm just gonna drop my weight down. I'm gonna drop my weight down through the patient's arms. So this is gonna mobilize T4 anteriorly on T5. So we know that's gonna help improve forward bending at that segment. It can help with improving rotation to the east side. It can likely also help with improving side bend to the east side. But but you see this middle finger is on wet, T4 on wet air, spinous process. So when I drop my force, what's T4 gonna do?
Interiorly.
Yep, it's gonna move anteriorly. So a lot of people ask, well, how your hand, like, it could be confusing if I just take a body and do this on a body. They're like, where's your hand placed? But on the skeletal, you can see it. You can see it better, segment by segment. I can go segment by segment doing this technique. But it's more beneficial in the mid-thoracic spine, because as you get lower towards the lower thoracic spine, what does the spinous processes start to do? They start to slope downward. You see, they start to slope downward. So your mid thoracic spine, T3, T4, T5, T6 is more so the beneficial area for this technique. All right. So that everybody get that, because a lot of students always come back and ask, where were your hands placed and how were your hands placed? So I'm showing you through the dummy. This is how the hand is placed. So it's just a pistol technique, right? Just means your hand is almost like a pistol in a sense. Really, my thumb, students also like to ask, what is your thumb doing? What is your index finger doing? What is my thumb and index finger doing? Nothing. It's just the formation of the hand. It's just the pistol formation of the hand. So where the spinous process is on what? My middle finger. So my middle finger is in contact with the spinous process. So this technique that we're about to do is really all about the setup. You get the setup, you got it. Some people take a towel and put it around these fingers here. I like to do that because it can, but it's still ultimately, when I put the towel down, I'm still gonna have the same contact with my middle finger. All right, Devonna, sign up for this technique. So go ahead and just lie down on your back for me.
What's the advantage of this versus doing a TA in front?
I think the advantage of this one would be more so the capability to just use your body weight. Now prone, you could do it prone as well, right? But your upper extremities is incorporated with it. But if you can get the patient low enough, you still can do it prone your upper extremity and drop your body weight. It's just preference of the clinician. You know, and sometimes it just becomes preference of the clinician. May not be an advantage, may or may not be. You know, I need a towel now. Let me see. Let me see that. Let me see that towel. Now, on the slide, it says to guide the patient down from the long sitting position. But you can also just have the patient do it like a little log roll. I think that'll help protect my finger good enough. Okay, so you just had a patient do a log roll, right? All right. And so, I'm gonna bias her because it's gonna be, all right. So, also on the slide tells you to bias, just to keep the head flexed. So it's good to have these tables that are adjustable to help out. Use these tables to your advantage. So now I don't have to hold and cradle her head into flexion, right? Because I have this helping me out. All right. So just roll over. Oh, sorry. No. Wrong way. Wrong tactile cue. Roll right there. I'm gonna go T4 on T5. So I'm going T4 on T5. So my middle finger is in contact with the spinous process of T4. Okay? I'm just gonna roll her back over. Roll back over onto my hand. I'm gonna lower her so that I can drop my weight. Okay? Cross your chest for me. Arms up like that. Take that off. Okay. I want to get up in here. All right. Go ahead, take a deep breath in for me. And blow out like blowing out of a straw. Got it. Mm-hmm.
Yeah, that was a good one.
I felt that one. She's tight. She's tight. I'm gonna go down the segment, okay? Okay, good. She probably needs this. I'm gonna make you go even lower. Okay. Good. Take a deep breath in for me. And blow out nice and slow.
Yeah.
Got another one. All right. Shake that off. No rotation.
Yes.
Look. Rhythmic inhalation. All right, one more segment and that's it. I'm gonna do mid thoracic. So did T4 on T5, T5 on T6. I'm gonna do T6 on T7. That's gonna be it for her. And take a deep breath in for me. And blow out like blowing out a straw. There we go. That's it.
Yeah.
All right. You're welcome. So, one thing I did, when she exhaled, at the end of her exhale, I tried to drop my weight down. All right, give me a big fella. I'm gonna lower him a little bit more. There we go. Let's see. It's hard to get in on this big fella. All right, take a deep breath in for me. Do I like blowing out a straw? Oh! Yeah, we got multiple segments, seem like, on that.
Yeah, I think we did too.
Okay, yeah. All right. Stay right there. You got some endorphins and then caffeine is kicking in.
Got something kicking in.
Give them my natural high. So you got to let them just sit there for a little bit. Let them calm down. All right. Give you a little laughing gas. Going on. Okay. All right. Now that Dr. McClure showed you, want to help the way how Olsen does it.
So it's
All
more
right.
specific to rotation.
Who wants to volunteer? For Dr. McClure. All right. What? Oh, y'all surprised he volunteered?
Alright, so you're gonna get up there on your back as well.
She's gonna feel nervous when I look.
So what I'm gonna do is I'm gonna have you cross your arms up here like this as well. You're gonna give yourself a hug, okay? So what I'll do is, again, really important. Get in here, support that there. I'll roll the finger knees, okay? I'll let you get there. I'm gonna have them log roll to me. And now what I'm gonna do is I'm gonna take, you can roll back for a second, sorry. The middle part of my third phalanx and my hypothenar eminence, and I'm gonna, instead of being on the spinous process, I'm gonna be on the transverse processes of two separate levels, okay? So we're creating more of a rotation, right? So if you remember, rule of the lower finger, Okay, right? So that's what I'm gonna do. So that spinous process is gonna sit right in that groove, and I'm gonna hit contact on the transverse processes like that, okay? So I'll come this way, find the level that I want to treat. There's spinous process, so I'm gonna get my position. I'm gonna come back, in fact, come down just a little bit, see, because we're gonna be right on the crack. There we are. You okay there?
Yes, sir.
Okay, and then I'm gonna turn my hand so that my third phalanx is on the superior segment. So I'm gonna come around like this and get her situated. I'm gonna get her elbows together as much as I can. I lost it. There we go. Get right in here. Have her take a deep breath and out. Like that. Okay. The other thing, you can also do this depending on what level you're at, and you can, if that's not like, I feel like it's having a hard time getting the slack, I can also have her support her head. Come here like this to get a little bit more ligamentous tension, right, to that level. Now I can use your arms. I can come up like so. Right there. Breathe in. And out. Okay. So we got it before I even dropped, right? Just from the setup. Very similar, but you're using more of a rotation mechanism to create. Instead of being right on the spinous process, you're getting on transverse processes, staggered. Okay. Same pistol grip. Support your fingers. Any questions about that? So that's the technique you'll see on that list. I think it says thoracic rotation
Yeah.
supine. Page 317 to 321. Yes.
The same technique can be done with the person prone, right? Oh, thank you, Dr. McClure. So that, the one Dr. McClure just went over, it takes, you gotta wrap your head around it because you gotta understand what you're doing with that rotation component. But it's a very good beneficial technique. The same thing can be done prone. Only thing, I'm using the headrest to help facilitate putting his head in flexion, so it doesn't have to be held in flexion, right? So same thing, I can come and then I can locate his TPs. I'm gonna go right here, T5 on T6. So I locate his TPs, right? So now I have my index finger on the TP of T6, and my middle finger on the TP of T6, right? So this is where sepals action doesn't have to be done supine. So this is prone. Now come right here, use the inner border of my fingers. I think I had a plenty low enough. Take a deep breath in, blow out nice and slow. I follow through, and there we go. Same thing. So that would improve forward bending. So if I did if I was talking about T5, so say I did T5 on T6, right? So that would improve forward bending the T5 on T6. Where would it improve backward bending? T4 on T5. T4 on T5 is the one above. We talk about top down. Yeah. All right. So remember, if I mobilize T5 anteriorly, it's improving forward bending of T5 on T6, but also backwards bending of T4 on T5. Right? Okay. If I'm improving forward bending of T5 on T6, what else am I improving? Rotation. It can improve rotation as well, because each facet has to move anteriorly for rotation, right? Can it improve side bending? Yeah, because with the up glide, you have an anterior movement as well. So if I side bend to the left, I gotta have an up glide with some interior movement on the right. See See, it's just the orthokinematics. If you go back to the orthokinematics slide, the foundations is all in that slide. You know, it's all in the book too.